During cash, flash.
Okay. So I think we are ready to start. We are not muted like that one time. Okay, cool. Here we go. Welcome to rounds. My name is Megan, and I will do our first two cases. What? Okay. I will do our first two. There we go. All right. So, this first gross image is not our case. It is actually a completely unrelated dog, and our case is a cat. My point in doing that was just that this case did not have a gross photo, and this gross photo was particularly spectacular with this extremely large periocular mass that smushes the globe to one side, and it is a similar, although not the same diagnosis. This dog also had some asteroid hyalosis, which is kind of cool. But our actual case is a cat, a 10-year-old spayed female domestic shorthair. They said that the globe looked normal, but it was exophthalmic with ventral displacement. The CT scan showed soft tissue mass dorsal caudal to the globe with fluid around it, which was brown. And that's pretty much the history that we got. So we have a dorsal mass, which is displacing the globe ventrally. Grossly, this mass was kind of like tenuously adhered to the globe itself. So you'll see that it's kind of weirdly separated and such. We need to switch it over to Celsin. All right. Yeah, that TV is being kind of weird. Oh, both of them are being weird. Oh, and maybe it is showing up over the thing.
I don't think it matters that much.
Eh. Ignore our heat haze. Dang it. Oh, I need to have the condenser in. All right. I am on it this morning. So here is our globe. And indeed, it is a pretty normal and quiet globe. And then here is our mass, which is kind of not well attached to the globe in our plane of section, but it's not going to end up mattering to us. And then here's another piece of the mass, which was separated from the globe and sectioned over here. So let's take a look at this mass. Wow. So we have this highly cellular periocular neoplasm. If we drop in closer, eventually, wait for it, there we go. We have some cells that are not really forming like great patterns, and oftentimes these cells are looking a little bit more spindle-shaped. But even up here, you may begin to kind of detect some degree of like cord or lobule formation. I do think there are better areas for the spindle-shapedness. Maybe over here. Wow. Yeah, the exposure is doing weird things too. I possibly didn't optimize it exactly. All right. Um, well, sort of ranging from spindle shaped to polygonal. And maybe, here we go. This is a good area for spindle shaped. Spindle shaped. And then down here, especially if you go in this direction, you increasingly get more of a lobulated pattern. And in addition to being lobulated, these lobules of neoplastic cells have this thick band of eosinophilic kind of hyaline material surrounding them, which makes a really cool looking pattern. Very pretty. And there's more of this material sort of between the cells multifocally. Very labyrinthine. Pan's Labyrinth, perhaps. That was a scary movie. Uh, and if you go over here to the necrotic area, so this is an area of necrosis, and some of these pink bands are surviving in this area of necrosis or remain, even though the cells are gone. So look at these lovely little deposited membranes. So we had a couple of differentials for this tumor, especially because it kind of ranged in terms of its morphology. We offered only a pancytokeratin, just trying to save the client some money. And here is our pancytokeratin, cytokeratin AE1, AE3. The brown is a positive result. And you can see that all of those cells, whether spindle or polygonal, are showing positive immunolabeling with pancytokeratin. So this is a carcinoma. And another really cool thing that we've got for this case, and is sort of the grand finale of the case, we did a PAS stain on it. And look at all these pretty membranes lighting up bright pink. You're even more striking if we go in a little ways.
Basement membranes just for accuracy.
Basement membranes. Look at them. They're so pretty.
Yeah.
Ah, we got a hobbit.
Wow.
I didn't know that was a thing.
Zoom. Beautiful.
Look at them over here in the necrotic area. They're gorgeous. Yeah. So, looking like a basement membrane deposition in this neoplasm, which is something that I haven't really seen in periocular neoplasms. So this is a really unique feature, kind of unusual feature for this cat. Long story short, this is an epithelial neoplasm, essentially a carcinoma, which is periocular. And oftentimes we kind of just have to get a clue in terms of its location just based on, or its organ of origin, that is pretty much just based on location. So in this case, its dorsal location suggests that it may have arisen in lacrimal gland. But you always want to consider other possibilities when you've got a periocular carcinoma. Keep in mind that the apart from like ocular surface, which didn't sound like clinically there was any sort of ocular surface involvement, you want to consider that the nasopharynx and the oral cavity are both pretty close to the eye, surprisingly so. Keep that in mind. Also keep in mind that maybe more so ventral to the globe, there is third eyelid gland and potentially your salivary gland, especially zygomatic salivary gland. But based on anatomic location in this case, lacrimal gland was our favored diagnosis. Cats will sometimes make spindle cell type carcinomas. And I would say that either in this case, this could be like a complex carcinoma, and some of those cells may be myoepithelial. We'd need more IHC to look into that, which we didn't do that. We're trying to save the client money, and we didn't do it on our own dime. Or it could just be that some of these epithelial cells are becoming a more spindle cell morphology, which could happen as well. So just kind of a neat presentation in a cat, and especially the basement membranes we just don't see every day. So we did not. I know we just did a pancytokeratin. We're just trying to be economical.
Maybe can you repeat the question?
Oh, the question was, did we not do a Vimentin? We didn't. I know. If we had done that, it would have helped us to see whether like the spindle cells also expressed Vimentin. Like if they're expressing both pancytokeratin and Vimentin, that would have helped us zero in on who the spindle cells were. We could have also run like a smooth muscle actin or something like that, which would have been interesting. So yeah, if we really wanted to dig into like why this tumor looks like this, we would have needed some more testing. But I think the main thing that they wanted to know clinically was, is this a carcinoma, and what was the likely anatomic origin? So we stopped there. Cool. Any other questions or comments? Okay. I don't know. The basement membranes are weird. I don't know what their significance is. I see. Interesting. Hmm. All right. So we'll do the next case. Oh, sorry. This is a cat. Again, we have a 8-year-old spayed female Maine Coon. This cat showed, they described buphthalmia, and a swelling or mass at the 11 to 5 o'clock position, with dyschorrhea, so weird pupil shape. So grossly, we saw a mass that was protruding through the episclera and into the bulbar conjunctiva. You can see the eyelids kind of displaced over here. So like here's where the palpebral fissure is. Here's eyelids. So this is all bulbar conjunctiva and episclera, which is expanded by this tan white mass. Here is iris on that side, which is also expanded and distorted by the same mass. And it's also involving ciliary body through to choroid back here. The choroid is still thickened and tan over on this side. And this iris is looking at least slightly more normal, comparatively speaking, at least. We've also got a fairly cloudy lens, and we've got a detached retina, which you can see back here. Okay. This case should be quick. I picked it because it was quick. Oh, and I already gave away the diagnosis. Dang it. Now it's really quick.
Like now we're done.
Now we're done.
Just visualize.
You've all seen this before, so let's go on.
Good. Oh my goodness. Yeah, I wanted to do this as a Not exciting case, just a straightforward case. But anyway, so here is this tumor. It's really purple, which means that there are a lot of cells. You can see that there's a similar population everywhere that we said it was grossly. And there's a lot of pink to it, which is going to be necrosis, and we can look at that closer. Oh, all right. Here it is again, in the iris and the episclera and the bulbar conjunctiva. If we zoom in closer on this population, it actually looks pretty not fun out here. Maybe kind of somewhat degenerate, maybe a little bit of artifact, like kind of poorly fixed in some areas. These cells are sort of shrunken on themselves, but they do have distinct cell borders. They're pretty distinct one from the other. They have a pretty high nuclear to cytoplasmic ratio with pretty big nuclei and often at least a single prominent nucleolus. If we go to other parts of the tumor, in particularly down here in the choroid, they become a little bit better preserved. Maybe, sort of. And they look a little bit more obviously round, or so. But similar features. The neoplastic nuclei tend to be, thank you. I'm making do, I'm muddling along. So the neoplastic nuclei tend to be maybe about 1.5 erythrocytes to 2 erythrocyte widths in diameter, which is useful for later. Here are some erythrocytes we could use as rulers. And something that I wanted to point out in this case, which is just kind of a neat thing to think about. Here we go. This is a good-ish area. So right here we have the RPE cells, so retinal pigment epithelium, and immediately beneath that we have these clusters of neoplastic round cells, which suggests that these cells may be involving the choriocapillaris. Generally, we don't really see the delineations of those tiny, tiny capillaries in that site, so you kind of just have to imagine that choriocapillaris is there. But if you have like clusters of neoplastic cells right at this location, it's suspicious. The other thing that was a little bit unfortunate in this case is the optic nerve is affected by artifact quite a bit. So all this sort of purplish strandy stuff is basically just sort of squished nuclear material or squished DNA. And there's a lot of necrosis in this area too. But basically the optic nerve up to our margin is looking pretty abnormal. So I'd be at least somewhat concerned about the optic nerve margin in this case, even though I can't confirm whether there are definitely neoplastic cells at the margin.
And typically, we never see that purple streaming in other tortured optic nerves that aren't affected
Yes.
by neoplastic cells.
Good
So
point.
yeah.
The amount of DNA implies that there were like more cells than we would expect at that site, basically.
Fragility.
Yeah, and fragile cells, actually also a good point. Yes. Fragile cells, so around cell tumors like this one can be pretty fragile in particular and be prone to exploding essentially, even with like minimal tissue manipulation. So,
In those endoscopic biopsies with lymphoid tissue, see a similar effect.
reflected in endoscopic biopsies with lymphoid tissue as well, you see a similar effect. That was the comment. So I'm being quick and moving on to really cool cases. So we're just going to show you the CD20. The CD3 was diffusely negative. The CD20 is diffusely positive. We've got really strong immunolabeling in cells. There you go. So B-cell lymphoma, as you already saw, pretty straightforward diagnosis. Briefly, the papers that have come out for both dog and cat, basically, you used to think about lymphoma in the eye as being like stage 5 lymphoma, right? Like that's organ involvement, means lymphoma is pretty advanced. But the things that we found suggest that that's not always the case. There are some lymphomas that can arise as a primary ocular tumor. So keep that in mind. And essentially staging the patient is all you can really do to determine whether or not this is like multicentric lymphoma that is also involving the eye or potentially a primary lymphoma confined to the eye. In this case, either way, there's concern that this patient may still have tumor cells in the body. So, all right, that is it. I will shift. So next up we have Dr. Gillian Shaw. Some really cool cases. Okay.
Alrighty. First up, we have a 4-year-old spayed female Pembroke Welsh Corgi. the history that we got. So there's no gross photo, but we got this beautiful clinical photo. Um, the history was on August 22nd that there was unwitnessed trauma to the right eye in the backyard in a Western state. Examined at ER and had hyphema, concern for abrasion, and sent on something I've never heard of before, ofloxacin and meloxicam. Wow. Anyway, 3 days later, at an initial ophthalmic exam, the right eye was blind with lateral perforation, presumably of the cornea, and large central bullae/corneal ectasia with yellowish tinge, and the anterior chamber was not visible. Um, so I'm going to withhold the rest of the history because it's really interesting. But anyway, so we got the globe, and I mean, this is the clinical photo, so that's that lateral area of perforation. So here's the medial canthus. Here's that area of lateral perforation. You can see that the cornea is kind of opaque and maybe looks a little bit expanded and wet. So corneal edema there. This is just prior to the enucleation. And the rest of the globe, I think, was pretty normal, except that unfortunately they had nicked it while they were taking it out, so it's kind of collapsed. So the state of the globe is not very pretty at the moment, but on the slide, I mean, the globe wasn't pretty in the dog's head anymore either. All right. So I have two different slides for this one, and I'm going to show you this one briefly and then switch to the other one. Here's the slide of the whole globe. So there's the cornea up at the top there, and you can see how pale it is, and that is because of really significant corneal stromal edema. We also have hemorrhage in the anterior chamber, posterior chamber, vitreal space, and the iris is also expanded by a bit of hemorrhage there as well. So there's a little tiny bit of maybe faint basophilia in the corneal stroma as well, which is some sort of infiltrate. We'll look at a little bit more closely, but I'm going to switch to our other slide, which better captures the entire, the perforation site. So here is what we call a nanner or a banana of the globe, where we have some sclera. Here's ciliary body at both sides, iris, leaflets right there, and then here's the cornea. So you can see that there's a defect in the cornea, and the iris leaflets are prolapsing up into that defect. So this is our corneal perforation, and this is just another section of it as well, where we're just catching the area of it. Wow, this monitor up there is having some problems. I mean, that TV. Anyway, all right, so let's look.
It looks like it's being highlighted by this.
It's really weird. Anyway, okay, so here is the defect. You can see it's ulcerated on the surface because the epithelium is present here, but not here. And then we have this cavitation where it's sort of filled with blood and probably aqueous humor and edema. And then some of the pigmented tissue here is the iris prolapsing up into it. We have this beautiful coiling of Descemet's membrane right here. I don't know if that necessarily implies anything about the etiology of a break in Descemet's membrane, but maybe you could imply that it's a high energy sort of kind of situation, sort of trauma. I don't know if that really plays out, but Descemet's membrane is quite elastic, so I think when it suddenly is broken, it can coil like that. Same with the lens capsule. Anyway, so what I also pointed out on low mag was that there are areas of iridoral stromal hemorrhage, and that is not necessarily a common finding in many globes, but we can see it in certain situations, including trauma. Sometimes when, especially in older cats that have hypertension, you can see iridoral stromal hemorrhage that's related to vascular disease. But other than that, it's actually relatively uncommon. So it's sort of a unique feature of this case. And now I'm going to switch back to the whole globe. Or kind of the whole globe, because it was collapsed. So there's more of that iridoral stromal hemorrhage, and what I'm pointing at, what I mean is this right here. It's blood that's not in a blood vessel. And similar over here, a little bit of hemorrhage here, and there's hemorrhage in all the ocular chambers. And then when we move back to look at the retina, So remember I said that there is an iatrogenic laceration of this globe. So that's what we're looking at right here. And that's has very blunt edges. There's no tissue reaction around it. So that's a pretty good indication that that happened either after they enucleated it or at the time of surgery because there's no time for the tissue to react. However, and also I should say, you can get retinal detachment when you have an iatrogenic laceration of the sclera during an enucleation surgery. However, what shouldn't happen is the retina completely losing all of its architecture right here. So this is a true lesion. So this is what a detached retina that can be iatrogenically detached would look like. So where you have very nice definition of all the retinal layers. It's just that it's not attached to the choroid anymore. But this is unique because we have this area of retina that's completely detached, and because it's starting to lose its architecture, that means it's necrotic. So we have a significant area of retinal necrosis. One of the fun things we say in Coplow is when the retina undergoes complete necrosis, one of the things we can still often find are the retinal blood vessels. So you can see they're still looking pretty viable here, which is pretty interesting. When we look back over in this other area, so this was a couple of days between the unwitnessed trauma and the enucleation. So what we do have here is shortening of the photoreceptor inner and outer segments. So we've shortened the frilly frills, the pink things, which are actually responsible for where all the phototransduction takes place, and that occurs relatively quickly after retinal detachment. And then what we also have is retinal hemorrhage, which is also, once again, a little bit unusual. Sometimes we'll see it with hypertensive, like vasculopathy kind of situations, but it's otherwise fairly unusual. So remember, this is a 4-year-old dog. So really, systemic hypertension is pretty low on the list. We have this vague history of unwitnessed trauma. So that's kind of unique as well. So this dog is from Colorado. And the history that I didn't share with you was that they suspected it was a snake bite. Um, and so let's go to my diagnoses now while I give you the rest of the fabulous history that we got. Um, so the rest of the history was that the 25th, August 25th, was when the dog was actually examined by the ophthalmologist. That evening, the owner was bitten by a rattlesnake in the backyard, was treated at the hospital, and they found only one puncture hole on this human's leg. And so the ER doctor speculated they may only have one fang. And I think this is relevant because snakes of a certain size, they have two fangs that maybe, yeah, because they just have upper fangs. So really there should be two puncture holes. And what we really are seeing here is maybe one puncture hole from this area of the cornea, and they didn't report anything else around the eye, which is kind of weird. You'd expect like periocular, trauma, edema, hemorrhage, necrosis, or something with envenomation by a rattlesnake with two fangs. Anyway, so I thought that was really interesting. So I think probably the dog and the owner were bitten by the same snake. Um, but anyway, so they ended up enucleating the dog a total of 6 days actually after the unwitnessed trauma. And so that's what we ended up having. So here we go. Owner bitten by rattlesnake and it had only one puncture wound, one fanged snake. Anyway, so these are all my diagnoses, the most important of which are relating to the cornea with this profound stromal edema with a perforation. We have a pretty acute rupture of Descemet's membrane, and then we have moderate intraocular hemorrhage, irritable stromal hemorrhage, and also retinal detachment, necrosis, and hemorrhage. So some of the common features that we see with rattlesnake envenomation in and around the eye is necrosis, hemorrhage, and edema. And so all of these things fit perfectly. So unlike the case that I presented a couple months ago where nobody believed me that it was a snake, I think that everybody believes me. This was a snake. Okay, cool. Any questions, thoughts, comments?
I wonder how often do they snakes bite and only one fang penetrates skin or
Oh, good. Yeah, I guess
Yeah.
that's another possibility.
Yeah,
Or like oblique.
gotcha, yeah, like an oblique angle.
an oblique angle or for example there in the eye, the fang that hit the cornea had a much easier time penetrating than the one
Yeah.
if the one kind of went into the skin, you know what I mean?
Yeah.
and also moving out.
So they invert them and move them laterally, and so they spread them out, so it's wider than the snake's mouth when they bite.
Okay.
And snakes frequently lose fangs. It's not a surprise, they just have more that move in, like sharks. And so all those things are plausible. I've seen eyes from rattlesnake bites look just like that, so
Yeah.
teeth doesn't surprise me,
Okay.
the eyeballs.
I got some doubters. It's okay. Whatever.
No,
I'm kidding.
I
No, it's fine.
I was just wondering about unilateral fangness.
Single fangedness. All right. Cool.
Everyone agrees with snake bites.
All right. Moving on. Okay. So the next one here is an eye from a 1 year, 8 month old golden doodle, neutered male. Came with sort of a fun history. Congenital orbital cyst with microphthalmia. So really they didn't even need to submit this case because they already got the diagnosis. So I'll just tell you right now, this case diagnosis, main diagnosis is microphthalmos with cyst. So they say it has been drained twice earlier this year. Clear fluid returns quickly. An MRI in March 2025 showed no other areas of concern. So I think because of this recurrent swelling, they just decided to enucleate. So they say has always had microphthalmia since 6-week-old puppy. Scleral / cystic changes noted at 8 months of age. So tiny eye for since puppyhood, and then this cystic swelling since 8 months of age. So for about a year, it's had this swelling. Anyway, so not that they told us. So the dog has previous seizures, but has been since taken off Keppra. Anyway, so we got the eye, and here it is. So there's the cornea, here's the globe. So when we hemisected it, so there was a fluid-filled soft cyst dorsal to the globe. The cyst was 2.5 by 1.7 by 1.5 millimeters. Sorry, centimeters. So we sectioned it all in one piece so we could appreciate all of it. This area here is probably conjunctival surface that was exposed a little bit because you can see there's some pigment on it. So we said the globe was microphthalmic, and you can see this is a 1 centimeter marker here. And so that is a pretty small globe coming from a golden doodle or a dog of any breed, to be honest. Adult dog. And that is about it. So we couldn't identify the optic nerve head grossly, nor could we identify the retina. So there we go. So what else can I point out here? So here's the cornea. It's a little bit cloudy, and then you can see this large cystic structure. It's very floppy. I don't know if it was turgid when we got it. Probably not, but anyway. Okay, let's go back to cell sends. Okay. So here's the cornea. Everything looking pretty normal up here. We have iris, we've got lens. Here's a bit of retina, so there it was. And here's this like beautiful defect in the sclera that we see here. And that joins up with this cystic structure, which is maybe lined by some cells. You can see here at least. We'll look higher mag. But yeah. And then the conjunctival epithelium extends over the surface of this, and you can see that this, because of how pale it is actually quite edematous. So let's go ahead and look higher mag. Oh, it's backwards, sorry. Anyway, let's start with the cyst. So there's that hole in the sclera. It's filled with some weird tissue. You can see that the tapetum here, which indicates that this is dorsal, kind of wraps around that edge of the sclera, and so does the choroid. And then the RPE kind of wraps around and kind of disappears into this jumble of tissue. This tissue, I think, is retinoid. So it looks vaguely like primitive neural tissue. So we're lacking any of the layers that we would expect to see in a normal retina. There's a little bit of pigment around too. I wonder if the pigment granules are oblong. They may or may not be. If they were oblong, then we could posit that they were coming from retinal pigmented epithelial cells, but I think they're actually pretty round. So those are probably coming from choroidal melanocytes. Anyway, moving on. So we'll just move to the opposite side of this cyst. Oh, sorry, that was out of focus. All right. So we are seeing an epithelioid, maybe more primitive neural or neuroepithelial tissue here that lines the entire surface of this cyst. Just to give you a nice example of what it is. I was trying to look and see what kind of surface it had. I'm not going to say anything more about it because I don't really know what to say about it. Anyway, so we suspect that this is primitive retina and that this primitive neural or neuroepithelial tissue is lining this cyst, and that the cyst occurred because of a failure of the optic fissure to close. And so we get this scleral defect, and then the retina sort of pooches out into it and continues, well, and I probably proliferates and grows to line the entire cyst, which is kind of interesting, considering we think retina should all be post-mitotic at birth. But anyway, so there we go. So the retina, there is some retina still in the globe. It is diffusely detached, and you can actually start to pick up a little bit of circular, rosetti kind of things, which is not uncommon, i.e., it is common in congenitally detached retinas and congenitally abnormal retinas, so a touch of retinal dysplasia as well. When I looked at the anterior segment of this eye, I kind of looked at the iridocorneal angle. I did look at the iridocorneal angle, and there's really no ciliary cleft to speak of. So we have the end of Descemet's membrane here coming right in and joining up with iridoid tissue, and it's kind of similar on the other side. And so I sort of vaguely thought maybe this globe also suffered from iridocorneal angle malformation or anterior segment dysgenesis. But it was not causing glaucoma, although all of that aqueous humor could have been shunted out into the giant cyst as well. There's also a cataract. So there's some cataractous degeneration of the lens. We have posterior migration of the lens epithelium, and then some jumbling and disorganization of the lens fibers. So we have a cataract as well. All right, so without further ado, no need to delay anymore. So generally, the biggest, most important diagnosis here is microphthalmos with cyst, equivocal, I said goniodysogenesis, or ASD, anterior segment dysgenesis, cortical cataract, which I presumed was congenital, and then diffuse retinal atrophy, diffuse retinal detachment and atrophy, plus or minus dysplasia. Cool. Any questions?
Could you call it a coloboma?
Oh,
Just wondering, because
Yeah.
the defect is lined by like the retinal tissue.
I
I
think
don't know if you ever see like a cyst formation with that, but
it is a colobomatous lesion.
okay.
But I think it's past that,
Yeah.
because of the cyst. I think the coloboma or the defect is implied when you have microphthalmos with a cyst.
I see.
But it's nomenclature, you know what I mean?
It's a specific manifestation of cold.
Okay.
Right, yeah, they're all defects on closure of the optic fissure.
Mhm.
Some of them, they're less severe, and I think you end up with just a coloboma, which is a defect that doesn't cause that bone. But I think when it's larger, and also depending when it happens, right, during the process of embryology of the eye, you might end up with a larger defect where now it creates a weakness where vitreous and aqueous gets access to and causes that cystic lesion, and the embryologic retina keeps developing and going over and following that cyst line.
All right. All right. I'm Jamie Miller. I'm going to finish up with the last two cases for rounds today. First up is a dog, a mixed breed beagle, 12 years old, female spayed. We ended up getting both eyes from this dog. This is, again, a representative photo because we did not have a gross photo of either of the eyeballs that were removed, but I thought this was maybe representative. So the history that we got in this Beagle mix is the left eye is diagnosed with end-stage glaucoma. They said the globe was ophthalmic and non-visual, and that there was hyphema of undetermined etiology. The right eye, they said it was more acute glaucoma, and it had anterior lens luxation and a hypermature cataract. So grossly, both eyes were fairly similar. They were both ophthalmic, maybe the left eye a little bit more than the right. The lenses were invariably either posteriorly luxated or subluxated with a cloudy lens, kind of like here. And we said the vitreous was thin in both eyes. There was maybe a little bit of hemorrhage in the left eye, when maybe not represented well in this picture. But we did say that the right eye had some white strands also in the vitreous, which can be seen here. So what's going on? I'm going to very briefly show the left eye from a subgross view because it's not the best looking. So cornea up at the top, we've got the intraocular hemorrhage that they noted clinically. The lens was a little bit harder to identify. We can see this bright pink material here, which is lens capsular. So it's discontinuous, so there is rupture. And our retina is detached, and again, some hemorrhage here in the subretinal space as well. So it's a little bit hard to make out much from the subgross, but I'm going to stick with the right eye, which was a little bit better. But they were fairly similar histologically. So again, cornea at the top. Here our lens is a little bit better sampled here, but we'll take a closer look at it as well. We have the vitreous here and the retina here as well, which is maybe looking a little shaggy here. There's some stuff kind of clumping around on the outside here. The same with a little bit here in the vitreous. There's a little bit purpleness here, and maybe kind of along our uvea as well. All right. So if we start at the front of the globe here, cornea on the left here, there's a little bit of vascularization, maybe some neutrophilic inflammation in here. There is a fibrovascular membrane lining the anterior surface of the iris. It does cross our iridocorneal angle here, so it causes peripheral anterior synechia. There's also some lymphocytes and plasma cells in the anterior uvea here, so some uveitis. Our membrane kind of does wrap around the back of the iris. As we take a closer look at the lens, we can see some cataractous degeneration and as well as these macrophages that are in here with this discontinuous portion of the lens is a little bit sharp. So again, as sort of stated earlier, a lot of times we will see a nice curling effect of the lens capsule when it does rupture, but sometimes we don't always capture it, and the lens was a little bit fragmented as well. But the presence of these macrophages that are intermingling here with these degenerate lens fibers are indicative of true inflammation. Got some nice more ganglion globules here. And so we do have evidence of lens capsular rupture and a pretty severe cataract. But then as we look at what is lining our surfaces here, we've got them lining our iris. Kind of look like they're tracking up the zonules here, and they're lining the back of the lens. Are these monomorphic cells that have some pleomorphism to them. Got a nice mitotic figure here. And so we've got these little clusters of polygonal cells with eosinophilic cytoplasm, nuclei round oval, kind of finely to densely stippled chromatin. And if we follow these cells around, we can see that they form a nice little line all across of our retina. And if we keep going, you can start to see some little We can see some apical blubbing of some of these cells. Some of these cells have this very large clear space and kind of push the nucleus out to the side and have this sort of signet ring morphology. We've got some cells in here that have some more paler staining stuff in their cytoplasm, so there's probably some goblet cells in here as well. And so it was just kind of fun to kind of follow this around and see sort of the branching and like tree patterns it sort of makes on the retina here. And then again, it is also lining the portions of our vitreous here. So these features are all consistent with a carcinoma, and this carpeting behavior in the eye is a pattern that we see with metastatic carcinoma to the eye. And those cells were present in both eyes, so it was metastatic into both eyes as well. I did throw on an Alcyon blue PAS for funsies. So we can see our lens capsule again highlighted very bright pink and magenta here. Get it in focus for you. You can see a little bit. There we go, a little bit here, some little curling and disruption. Again, good for lens capsule rupture. And then if we find a nice spot, we can see some of the goblet cells being highlighted here with their sort of mucinous stuff in their bellies. So a nice little boop, boop feature there. We've got yeah, kind of a spooky maybe diagnosis, a bilateral metastatic carcinoma in the eyes. It also had bilateral cataracts with lens capsule rupture in both eyes, both of them with histiocytic phakitis. Oftentimes, spontaneous lens capsule rupture in dogs is due to intumescent cataract, and with it being both eyes, was wondering if maybe this dog could have also been diabetic on top of that. Just kind of interesting things to consider. But for the metastatic carcinoma, often we think of like respiratory origin, so nasal cavity or lungs, which is highly suspected maybe in this case. We could also get squamous cell carcinoma, maybe stuff from the GI tract leading to the eye. What was that?
Ever seen pancreatic?
Pancreatic metastatic to the eye? Anyone seen
Not
that?
that we confirmed, no, I mean, yeah, exactly. Potentially, yeah, but not that we confirmed, not that it was confirmed as pancreatic. That's a good one.
Would pancreatic have goblet cells?
No, not necessarily, but they'll have secretory material.
Ah,
I'm pretty sure we did have one case that was confirmed as metastatic gastrointestinal.
Yeah. That for sure, a gastric carcinoma, that's what
Gastric.
Megan said,
Mhm.
that was confirmed. Yes.
That's pretty cool. I mean, not for the patient. It's cool for us.
Okay. All right. So, gonna finish up here. Uh-oh. Can you recap the conversation for us? Yes. So, there was a question on if we've seen pancreatic carcinoma metastatic to the eye, and nothing that has been confirmed as such. Probably wouldn't have goblet cells, but would have maybe secretory material associated with it. But we did have at least one case of confirmed gastric carcinoma that has meted to the eye.
And that one had pretty impressive signal ring cells that we end up with a PAS because it was, the days where we got PAS and everything. It was beautifully positive secretory material in their cytoplasm.
Excellent. All right. All right, so to finish up here, we've got the right eye from an 8-year-old male neutered domestic short-haired cat. Again, this is a representative photo, not from this case specifically. But what was reported to us was this right eye had 3+ flare, had some ventral fibrin, presumably in the anterior chamber, had a fixed mid-range pupil and multiple areas of posterior synechia and rubeosus iridis, a mature cataract, and also negative menace, PLR, and dazzle. They do note that the other eye did have some trace flare a few weeks prior, but it had resolved with prednisolone twice daily. They note that they did do a fungal panel, which they noted to be positive for histoplasma antibody, but not the antigen. So that was an interesting piece of information, and we'll hold on to that. So grossly, we said that the globe was thesical, which would be represented here by this kind of undulating, wavy posterior portion of the sclera. Normally it should be nice and round. So we've got some shrinking in of the sclera there. We did say that there was some tan tissue in the vitreous as well as the subretinal space, which would be represented here. Lens again, cloudy cataractus as well. So we will take a closer look at our histology case. Right. Here. Right. So cornea up at the top, looking pretty unremarkable. Here is our lens, which we can see again, looking a little choppy here. There's a lot of hypercellularity, purple stuff here that does travel around into the vitreous. We've got our ciliary body, or sorry, our choroid here is expanded by some clear space. We've got some hemorrhage. We've got this tissue here and some hemorrhage, which ends up being the detached retina that we'll take a closer look at. And then this is just an extra section of our globe to just get a better look at more of that material that is in the vitreous and the posterior chamber. Oh, and then we can also see the scleral wrinkling to go along with the thesis bulbi. So, as I mentioned, from subclose, the cornea was fairly unremarkable. We do have the anterior uvea here. There's some moderate number of lymphocytes plasma cells in here, which we can also see in the choroid, which is also kind of expanded by edema and some clear space. And then what we do have is we have this kind of fibrovascular membrane that lines the ciliary body and kind of spans the choroid, the epichoroidal space. So that's probably what's pulling on our scleral tissue, causing it to be wrinkled, which contributing to the thesis bulbi. This is our detached and kind of jumbled up retina here with some hemorrhage. And we have a big cellular infiltrate in here, which we'll take a closer look at. And it's a mixed inflammatory cell population here. So we've got a lot of neutrophils in here, these little segmented nuclei. We've got some macrophages, and there's a lot of this bright eosinophilic globular stuff in here, which is actually coming from the lens. So if we travel back forward, follow this cellular infiltrate around to the front here. Oh, this was the piece that I wanted. We see that our lens capsule is discontinuous, and it is also being infiltrated by this inflammatory infiltrate. So we've got this lovely fraying here. And if you can get a little bit closer, we start to see that there's a few little friends here that have come along for the ride here. And so we've got this brown pigmented hyphal structures. And so we have some nice fungal hyphae in the lens as well. If we scroll around, we can start to see that there's a fair number of them. They have kind of parallel walls. Some of them are a little bit bulbous. I'm going to follow this along because it gets really good, even better. Go over here. Ooh,
Beautiful.
So lovely. We've got maybe some acute angle branching going on here, maybe a couple septations here and there. So we have pigmented fungal hyphae in our lens. This is phaeohyphomycosis. Probably the big question here is, did this get implanted from a traumatic event, or is this possibly systemically involved kind of infection? They weren't very easy to see on the H&E in the vitreous, but I did a GMS just to look for them more. So if we head back up to the lens capsule, you can see that it highlights them even better. We get a little bit larger section of the lens capsule. And so we can see all these fungal hyphae that are lovely, beautiful, awesome looking. And then if we scroll over to our vitreal inflammation, we can see that they are also here in the vitreous as well. So maybe possibly even a higher concern that there might be more systemic issues going on with this cat. What's also concerning is that they did report trace flare in the other eye. So is there something inflammatory going on there because of the fungus? Unclear. I did happen to speak to the clinician yesterday, serendipitously, because they had some questions. And she did note that the cat did have a chronic rhinitis that they were suspected to be herpes virus related. But it sounded like maybe after they enucleated, there might have been more mucopurulent discharge. So wondering if maybe there's also some nasal involvement with this fungus. So what? Sinus involvement, yeah, as well. But the cat, I believe, is heading to an internist, so hopefully they will parse that out and get more information about that.
So in general, we think about, well, every time we see lens capsule rupture and microorganisms inside the lens, that a contaminated penetrating trauma is most likely. But in this case, the large numbers of fungal hyphae in the vitreous with the systemic history really suggests a systemic infection. And got to remember that fungal organisms, especially hyphae, have a tropism for basement membranes.
Mhm.
And one of the thicker basement membranes we have in the eye is the lens capsule. And they are able to actually infiltrate and dissect between. So it could be a situation here where there is it started as a fungal endophthalmitis, and then the organisms got a hold of the lens capsule, infiltrated the lens capsule, and caused the lens capsule rupture.
Yeah. So there's several genera of fungi that are pigmented, and even Aspergillus can rarely produce pigment sometimes. As identification of the fungal hyphae, as far as which genus it belongs to, it's not something that we can do based on the morphology on histology alone. So we need something like tissue culture, IHC or PCR, which I did offer to them in case it might be helpful, which Florida has a PCR that we will send to, and it's dependent on, how many fungal hyphal organism or fungal organisms in general you have in there, if they are able to catch it.
And also the length of formalin fixation.
And length of formalin.
Paraffinization.
Yeah, length of formalin fixation before paraffinization might degrade some things with further PCR. And then again, it would only identify like the genus of the fungus. It won't give any sensitivity results or anything like that for treatment, but just extra pieces of the puzzle to help potentially. So.
No histoplasma.
And no histoplasma was seen with the GMS or regularly. Doesn't mean it's maybe not there if there's antibodies to it, or it was there in the past, maybe.
Yeah. I'm kind of skeptical. Yeah, I think we actually talked about it here at Coplow, how the antigen and the urine antigen and antibody tests for fungal organisms, when they're related to the eye, there's a lot of cross-reactivity. There's a lot of not false positive, but positives that are not necessarily related to the ocular disease, or in common situation is, well, let's put it false negatives where there's an infection in the eye, but there's not enough circulating antigen to cause a positive test result because of the, how secluded the ocular tissue is, or the organisms might be inside the eye. All right. Well, thanks for joining us, everyone. Have a good rest of the week and see you guys in 2 weeks.
Oops. All right, I can just end the meeting, right?
Just end.
Yeah.
I have a
I feel like